Dentistry is re-emerging out of the restrictions brought upon the COVID-19 pandemic. Hence the title of our working group, Phoenix. This group produced the first document, Provincial Dental Board of Nova Scotia, Reopening Plan for the Dental Clinics, Emergency and Urgent Care. This will be presented today to fulfill a requirement from Dr. Strang, Chief Medical Officer of Health, and the Department of Health and Wellness. Second document produced by the Nova Scotia Dental Association, led by Dr. Neda Haidar, is a companion document which helps operationalize the first. Occupational Health and Safety has mandated that each office develop a site-specific plan subject to government inspection. And these two documents can help you to develop that plan. A lot of great work was done, and I'm very proud of both teams. I'd like to proceed with the introduction of our panelists today. First up will be Dr. Kevin Walsh, Chair of the Phoenix Working Group, past Chair of the Provincial Dental Board of Nova Scotia. Dr. Curtis Gregoire, Deputy Registrar of the Provincial Dental Board of Nova Scotia, Program Director of the OMFS Residency Training Program at Dalhousie University. Dr. James Brady, Oral Maxillofacial Surgeon, Nova Scotia Health Authority. Ms. Marina Crawford is a Registered Dental Assistant, Provincial Dental Board of Nova Scotia Government-appointed Board Member. Dr. Neda Haidar is a Chair to the Return to Practice Committee, Nova Scotia Dental Association past President. Dr. Joanne Thomas, current NSDA President. Dr. Martin Gillis, Provincial Dental Board of Nova Scotia Registrar. Both documents will be presented, followed by a question and answer session. Closing remarks will be provided by Dr. Thomas at the completion of the presentations, and Dr. Martin Gillis will close the session at the end of the Q&A. I congratulate both of our organizations for the tremendous collaboration and coordination that was required to arrive at these documents. I now pass the controls over to Mr. Don Morris, partner at Temple Scott and Associates, who will chair the webinar. Over to you, Don.
Good morning, everyone. Thank you, Dr. Albert. As Dr. Albert mentioned, we will be running the Q&A session after the presentations from the Provincial Dental Board of Nova Scotia, as well as the presentation from the Nova Scotia Dental Association and some closing remarks from Dr. Thomas. To ask a question, you will use the chat function of the Zoom app, which is located at the bottom center of your Zoom app. Please feel free to type questions throughout the presentations, but we will only be taking them up after Dr. Thomas's closing remarks. With that, I'd like to pass it over to Dr. Kevin Walsh, the Chair of the Provincial Dental Board's Phoenix Working Group. Dr. Walsh.
Welcome, everybody. Thanks for joining us on this Saturday morning. I'd like to take a few minutes to review how the Provincial Dental Board has developed this plan, as well discuss how procedures are categorized. So as we know, knowledge and recommendations are rapidly changing during this pandemic. So this document is intended to be fluid, and it will be updated as required. On May 1st, as the curve was flattening, the Dental Board struck a committee to lay out a back-to-work plan that would be in the best interest of Nova Scotians. Considering safety and meeting the needs, a terms of reference was drawn up. Our initial emergency action plan that was developed for phase 1 would have to be significantly modified. Timing and phasing in considerations would be important, although ultimately this is up to the Office of the Chief Medical Officer of Health. Stakeholders would be consulted for feedback, and the plan would be based on considering current rapidly changing best practices, how to mitigate risk, including developing infection prevention and control protocols. Our document, referred to as Phoenix, represents dentistry's emergence from the ashes. This group was comprised of members of the Dental Emergency Working Group, where this group was already very familiar with the dental considerations of this pandemic. Representatives included registered dental assistants, dentists, and a public member from the Provincial Dental Board, NSTA member, QE2 Oral and Maxillofacial Surgery Department, the dental consultant from the Department of Health and Wellness, and Dalhousie University. We also consulted other Canadian jurisdictions, other countries, and stakeholders from other oral health groups. In addition, a subcommittee was formed called the Stakeholders Advisory Group, which consisted of representatives from the Nova Scotia Dental Assistants Association. So your president, Ms. Natalie Marsh, was on our group and gave us a couple of points of feedback that were incorporated. So thanks for that. The College of Dental Hygienists of Nova Scotia, dental specialists, dental office administrators, denturists, the IWK, dental labs, and suppliers. The principal considerations included developing a safe plan that relied on science and evidence-based principles. One of the key considerations is that both patients and staff are to be pre-screened for being possible carriers of COVID-19. Since the curve is now beyond flattening and bottoming out, clearly it's in the public's best interest for us all to return to practice. So yesterday we had our first day of 0 cases. So certainly the situation in Nova Scotia is improving. A draft document was compiled and delivered to stakeholders on May 7th. They were given 2 days to provide feedback. Dr. Strang then received the document on May 13th, followed by a meeting May 15th, with his office, which included the 4 dental regulators: hygiene, denturists, labs, and the Provincial Dental Board. On May 17th, Dr. Strang provided feedback with very few minor edits to incorporate our plan, and a few follow-up meetings with his office have occurred. So May 22nd, the joint reopening plan was submitted to the Department of Health, and now a reopening plan has been announced, was announced by Dr. Strang on May 27th. So it's been over 2 months since Nova Scotians have had only emergency dental care. And as we all know, dental issues are piling up. The initial dental emergency working group allowed emergency care only, which was provided by 8 clinics in the province. And I'd like to thank Riverside Clinic in Sydney River, Southwest Dental in Yarmouth, Citadel Surgery, the Lakes Oral and Facial Surgery Center, Dr. Ian Ross, the Dalhousie Clinic, which was instrumental in helping develop some of our protocols and early on at volunteering, the IWK, and QE2 Oral Surgery Department. So everyone there was quick to volunteer and provide this critical service during these unprecedented times. So thanks a lot for that. So our proposal was to return by reopening offices in phases and providing emergency and urgent dental care initially, closely followed by a final phase allowing non-urgent care. This plan was developed over 2 weeks ago, and the COVID situation is significantly less worrisome since then. On May 27th, it was announced that all dental offices can return to providing emergent and urgent care on Friday, June 5th, and we can return to non-urgent care on Friday, June 19th. The following slides will give examples of treatments that fall into the various categories. It's not intended to be an exhaustive list, and clinical judgment must be used. So we should all be familiar with emergencies by now. Infections with swelling, uncontrollable pain, trauma, and prolonged bleeding. So now all of us, including the initial 8, will be able to provide emergencies to our own patients. Urgent care focuses on the management of conditions that require immediate attention, including severe pain and/or the risk of infection. The idea during the pandemic is to treat these cases as minimally invasively as possible and to minimize the use of aerosol generating procedures. And the document speaks more to the details on this. Provisions of all emergent and urgent care may begin Friday, June the 5th, and the ultimate decision when offices reopen does lie with each office, provided it is not before June 5th. So this list is not intended to be comprehensive, and again, use your judgment. So things under urgent include things such as pulpal inflammation, pericoronitis, TMJ, facial pain that can't be managed pharmacologically, post-surgical follow-up appointments, trauma such as avulsion or luxation, dental treatment prior to critical medical procedures, post-surgical complications or dry socket treatment, abscesses or localized bacterial infection that result in pain or swelling, tooth fracture that results in pain or causes soft tissue trauma, final crown and bridge cementation if the temporary is lost, broken, or causing issues. A biopsy of abnormal tissue also would fall under this category. Managing of orthodontic issues that prevent causing further harm to the patient, suture removal, denture or appliance repair when function is impeded, and dealing with endodontic complications that are causing pain. And finally, non-urgent care basically includes everything else. And we may begin to provide this beginning June 19th. And ultimately, Dr. Strang's call, providing he still feels that this is safe to do so. We don't want to get a Campbellton situation here, and things like that may delay opening, but that's the date that we're currently going with. So routine examinations and radiographs would be non-urgent, routine dental hygiene procedures and preventive therapies, initiation of orthodontic treatment, asymptomatic extractions, operative dentistry on asymptomatic carious lesions, aesthetic dental procedures, laser instrumentation, dental implant placement, routine, fixed, or removable prosthodontic treatment, and non-urgent periodontal treatment. So that's pretty much it. Thanks to everyone who has worked tirelessly on the plan. Everything has evolved at lightning speed. We realized that we'd all like to have returned to treating our own patients sooner. However, to be safe, we felt strongly that process needed to be followed. And it's my belief that Nova Scotia handled this crisis safely with our best interests in mind. I'd now like to pass the presentation on to Dr. Curtis Gregoire, Division Head, Department of Oral and Maxillary Surgery, and the Deputy Registrar of the Provincial Dental Board. And Dr. Gregoire will discuss screening followed by PPE considerations. Thank you, everybody.
Thank you, Dr. Walsh. So as Kevin mentioned, I'm going to review what I feel to be the most important part of the guideline, which is screening. So there's two components to screening. First is procedural screening, which should be done at the time the patient contacts the office to make an appointment. So they should fall under one of the categories of either urgent or emergent care, which Dr. Walsh has just outlined. If so, then they should be screened for COVID-specific screening criteria. So this should be done at the time the appointment's made, and it should be repeated when the patient arrives to the treatment facility prior to being allowed entry into the facility. So what we're using for our screening tool is what's called the risk assessment criteria. So it's a list of symptoms and COVID risk factors. This differs from the surveillance swabbing criteria, which you'll see on 811, which is a list of 11 signs and symptoms, which is intended for just that purpose, surveillance. So if we look at the risk assessment criteria, which we're using in our document, the symptoms include fever, which is defined as a temperature greater than 38 degrees Celsius, feeling feverish, which would include chills, sweats, muscle aches, lightheadedness, new or worsening cough, sore throat or difficulty swallowing, new or runny nose, new or worsening headache, and shortness of breath. The risk factors which the patient should be asked about would be close personal contact without personal protective equipment with a suspected or confirmed COVID-19 patient within the preceding 2 weeks, travel outside of the province within the preceding 2 weeks, and whether they reside in a facility or a hotspot with a known COVID-19 outbreak. So based on those screening questions, if the patient is deemed to have 2 or more of the symptoms listed above and has not been tested for COVID-19 or the virus that causes COVID-19, it should be directed to call 811 and make arrangements for testing. If the patient has any one risk factor, the treatment again should be deferred until or unless it's deemed to be a true dental emergency. So for patients who screen positive, that being 2 or more symptoms or any risk factor, who are assessed and found to have a true dental emergency, they should be referred to a facility that has the infrastructure to provide dental care using airborne precautions. So airborne precautions would be things such as operatories with floor-to-ceiling walls, doors, appropriate negative pressure ventilation, PPE and observation of settling times based on ventilatory parameters. So the idea with our screening tool is you're screening out any moderate, high, or known COVID positive patients. So we're seeing very low risk patients. In other words, we're keeping the virus out, the intention out of our offices through screening. So next I'm going to discuss personal protective equipment, or PPE. Before I do that, I want to take a few moments to review some key concepts. The first is the concept of hierarchy of controls. So this is a group of guiding principles which are designed to mitigate risk of occupational hazards and protect workers. It's not specific to any one discipline, but I find it extremely pertinent in the context of the current SARS-CoV-2 outbreak. These principles were designed by NIOSH, which stands for the National Institute for Occupational Safety and Health. Dr. Brady is going to elaborate on this when he discusses masks and respirators. As you can see from the diagram, it describes 5 levels of protection, and not are all necessarily applicable to dentistry. So they're ranked from the most effective being at the top to the least effective at the bottom. So you can see personal protective equipment, a lot of talk about that, but it's actually the least effective means to protect patients and oral health care providers from contracting infectious diseases. So when we start at the top with elimination, this would be analogous in our offices to screening. So as I mentioned, very important to appropriately screen patients at the time the appointment's made, and repeat that prior to allowing them entry into your facility. Because if you do that, you're going to keep the virus out of the facility, protect healthcare workers and patients. The next would be substitution, which is not really applicable in dentistry. Engineering controls is the next level. So these would be things in our offices, such as modifications and waiting rooms to allow for physical and social distancing, plexiglass barriers at reception, use of surgical masks for healthcare providers, oral healthcare providers, appropriate scheduling of patients to minimize the number of patients in the treatment facility, and overlapping of appointment times, and the use of hand sanitizer. As we move down to administrative controls, these are things that we implement while we treat the patients, such as four-handed dentistry, high volume evacuation, rubber dams, pre-procedural mouth rinses, and strict infection and prevention control measures. So these are all things that we did prior to the COVID outbreak, and we did a very good job of doing these things, and we should continue to do so going forward. Okay, so next I'm going to talk about PPE. So historically, it's been used in dentistry. Its intended purpose was to protect dental health care professionals against bloodborne pathogens. Keeping in mind, PPE only forms one of our profession's standard precautions, which were formerly known as universal precautions. So just as a review, standard precautions include hand hygiene, use of PPE, which is slightly different, which we're going to discuss later in the discussion. Respiratory cough etiquette, again, so healthcare or oral healthcare professionals and patients should be instructed to cough into their arm or a tissue. If they use a tissue, they should discard it into the garbage and perform hand or arm hygiene afterwards. Sharp safety, safe injection practices, clean and disinfected environmental surfaces. So again, these are all things we do on a daily basis in our practices. So it's nothing new, and we should continue to do a good job at it going forward. Now, when there's a pathogenic outbreak within a community or healthcare facility, transmission-based precautions should be implemented in addition to standard precautions. So transmission-based precautions are a second-tier basic infection control and are intended to be used in addition to standard precautions. So by doing this, we're adding another layer of safety in caring for our patients. So what are transmission-based precautions include? So contact precautions, droplet precautions, and airborne precautions. So contact precautions would be things such as patient placement. So we do a good job of this. We use a single room for our treatment. Appropriate PPE, limit of movement of patients inside and out of the room. So when you bring the patient in the room, perform the care, and then have them exit the facility immediately afterwards. The disinfection of rooms. Again, we do a good job of this. Droplet precautions include the above. In addition, cough etiquette. And again, we're encouraging patients to wear masks to our facilities for care. As I mentioned earlier, airborne precautions are being observed only for high-risk patients or known COVID positive patients, which we should not be seeing in our offices if they're appropriately screened. Next, I'm going to ask Dr. Brady to discuss masks and respirators.
Thank you, Dr. Gregoire. So we're going to talk about masks here for a little bit, masks and respirators, and just kind of do an overview of what is out there. So on the far left here, we see surgical masks. These are the devices that we're all used to seeing around the office. So surgical masks can also be called medical masks, and that's how they're referred to in the literature. And basically, it's a device, I say, that can either loop over the ears or tie behind the head, and does two things. It provides a level of water resistance to protect you, the provider, from droplets and spatter from the procedure or the patient, and also protects the patient from droplets potentially coming from you. On the right, we see two different types of respirators. Now, these are distinctly different pieces of technology. You can have like an N95 respirator or an elastomeric half mask, also known as a gas mask, both different types of respirators. Now, all respirators, when used as part of a respiratory program, are meant to be fit tested to make sure that they're doing their job, and that is to keep out very fine particles and aerosols. So typically utilized only when recognizing airborne precautions. Next slide. I found this Venn diagram very useful as far as just trying to figure out what's what when it comes to masks and respirators, and then within respirators, a little more clarity there as well. So on the far right with the yellow circle, we see surgical masks. These are FDA approved, and these are all 3 levels of masks, are ASTM levels 1, 2, and 3, and they all afford some level of fluid resistance. On the far left, we see our N95 respirators, and prior to COVID-19, all respirators would be NIOSH approved. Now, only respirators that are both NIOSH approved and FDA approved, where these 2 circles overlapped, are considered surgical N95 respirators. So a lot of folks may have acquired some PPE in preparation, throughout COVID-19, or maybe had some left over from, H1N1 or something like that. And now you can go back to your office and look and see, what is it that I have and where does it fit in this Venn diagram? Is it the far left? Are they just commercial grade N95 respirators, or are they actually surgical N95s? And it should be very clearly stated on the box what you have. The reason why it's important is that if you chose to use an N95 respirator, if you did happen to have commercial grade respirators, these don't have any kind of standardization with respect to fluid resistance. Easy to achieve that. You would just have to put a surgical mask, any level, over top of that to give you that fluid resistance, or a full face shield would also give you that fluid resistance. Next slide. So KN95, what are these? Why are we all of a sudden inundated with texts and emails if somebody has KN95s? The reason why these are out and about and available stems from CDC and NIOSH recognizing that respirators were and are, probably will continue to be, in short supply. So in an effort to improve supply, they've allowed other countries' N95 equivalents to be recognized, at least temporarily, in North America. So this is a nice chart that just kind of summarizes different standards used throughout the globe. So you see the first column has N95, and it appeals to the NIOSH class standard, as opposed to the KN95, that's a China-based mask, and their standard is the GB 2626 2006 standard, So not as catchy a name as NIOSH, but it's basically a NIOSH equivalent. In the UK, that have an FFP2 or an FFP3, that's their N95 and N99 equivalent, and their standard is listed there. And you can see these boxes just show how these standards are similar, but different in their own little ways. One of the things I heard early on, and one of the questions was, does a KN95 need to be fit tested? Well, certainly if you're using it in the setting of airborne precautions, if you're in a hospital or a clinic that can recognize airborne precautions, for a symptom, a positive patient, a COVID-19 patient, or someone at risk, then it would absolutely need to be fit tested in order to make sure it's doing its job. One of the potential areas of confusion is that a lot of these other countries do have as one of their tick boxes less than or equal to 8% leakage on humans. So that's not to say NIOSH doesn't test on humans. That's just not one of their tick box. At the end of the day, when you have one of these devices and you want to use it as part of a respiratory program, it needs to be fit tested on the person going to wear it. The other area of confusion is, well, they only make one size. That, once again, doesn't mean that if you want to use a respirator effectively as a respirator, it doesn't need to be fitted. I say that would be like if Nike started making size 13 shoes only. Well, you might have to switch to Adidas and go back to your size 10. So at the end of the day, the device that you're considering using would need to be fit tested, once again, if you're going to use it for that specific reason. Next slide. So back to masks. Next slide. So within masks, we have different levels of masks. That's our ASTM levels 1, 2, and 3. So we sort of dug into this a little bit as well, just to kind of debunk, demystify what's the difference between these different levels of masks. Because if you just go on a vendor website, I believe is a little misleading. They make suggestions which aren't found in science. And when you actually do dig into the masks data a little bit, you'll actually be surprised, or at least I was, to realize how good all three levels of masks really are. They all have high level cloths or fabrics used, high levels of bacterial filtration efficiency and submicron particle filtration efficiency, flame resistance. The biggest variable was their fluid resistance. Now, to test this, they use a very specific test. It's the F1862 test, where they actually shoot 2 cc's of synthetic blood at the mask from a distance of 30 centimeters and to see how much gets through. And they do it at different velocities and pressures. So you see a level 1 is resistant up to 80 millimeters of mercury. A level 2 is 120 and a level 3 is 160. So why did they choose these different pressures? Those are to reflect using these in a surgery fashion where you could get a venous bleed, i.e. 80 shooting directly against your mask, versus an arterial bleed, varying levels of arterial blood pressure, obviously, or like a surgical orthopedic saw. So not really translatable to the dental profession specifically, where we typically don't have high velocity fluid and blood shooting directly at our masks. It's mainly droplet and spatter. So at the end of the day, certainly within the medical literature, when they make suggestions with respect to medical masks and surgical masks, they recognize that all three levels are very good. So now what do we need? Once again, dug in to see what was out there with respect to respirators versus medical masks in a clinical setting. Because it's one thing to have a benchtop study, but it's another thing to see what's actually clinically applicable. Because at the end of the day, we're out there dealing with real patients, and we want to make sure we're safe. Luckily, fairly recently, 2019, in the Journal of American Medical Association, JAMA, Rudanovich et al. Did a fantastic, very expensive, prospective, randomized controlled trial. It was US based, out of 7 different major hospitals, 137 clusters, and 2,862 participants. And this was over 4 flu seasons. So these were people working on dealing with people that were in isolation on airborne precautions due to influenza. So these were often febrile patients, and they were doing procedures on them, and it involved all sorts of clinical settings. So ICUs, dialysis clinics, there were some dental clinics involved as well, a lot of different sites. And once again, over 4 separate clinical flu seasons. And these people had to be followed very closely. They would log in on a daily basis and report any symptoms. If they had any symptoms, they would swab them. Even if they didn't have any symptoms, they would do serology on them periodically to see if they had, developed immunity to these airborne viruses. And what they found at the end of the 4 flu seasons is what's stated here. Among the outpatient healthcare personnel, the N95 respirator versus a medical mask resulted in no significant difference in the incidence of laboratory confirmed influenza. So important, well done findings here. Next slide. Even more recently, Long et al. Did a systematic review and meta-analysis that incorporated this study by Radonovich et al., as well as 5 other prospective RCTs. There was 4 done by author McIntyre, and another one done that was Ontario-based in 2009 by Loeb et al. And what they found after grouping the data together from all 6 prospective RCTs was, once again, N95s were comparable to surgical masks when dealing with these patients.
Okay, so next I'm going to discuss lab coats and gowns. So before I start, these garments, protective garments, are distinctly different from protective clothing, which you'll see in our table. So protective clothing is things such as scrubs or dedicated clothing that you wear within your treatment facilities, which should only be worn within the facility and not worn outside. So these are garments that are worn over top of your protective clothing. So the 2 main examples would be lab coats. We're very familiar with lab coats, pictured here on the left. And then gowns, which you may or may not be as familiar with depending on the nature of your practice. So they work equally as well, serve the same purpose, put on differently. So obviously lab coats are put on from the back, whereas a gown's put on from the front. So looking at gowns, similar to what Dr. Brady discussed with medical masks, there's different levels. I'm not going to get into it because the message to take from this is that all levels of gowns work for the purposes of general dentistry. They're primarily disposable garments. That said, you can find reusable. So disposable garments such as gowns should be doffed or taken off before you exit the treatment area and disposed of in a receptacle, a proper garbage receptacle. Similarly, if you have reusable gowns, they should be placed in a linen bag and doffed prior to exiting the treatment area. So lab coats, again, we're quite familiar with lab coats. If you're planning on ordering or buying lab coats, a few tips or pearls. There's different ways that they secure in the front, buttons, snaps, zippers as well. I find snaps are the easiest, just in the sense to doff or take off. That said, zippers and buttons will work as well, but you just have to be a bit more cautious when you're unfastening the buttons or zipper. If you look at cuffed versus non-cuffed, again, cuffed obviously is going to provide a bit more protection around the wrist and lower arm. That said, non-cuffed lab coats will work just as well. If you have non-cuffed lab coats, which I was using in one of the 2 emergency dental clinics I've been working in over the past 11 weeks, we would wrap our gloves or tuck the cuff under our gloves to, again, add an extra layer of protection. That said, the combination of gloves and lab coats that you have available to you, you can't tuck the lower part of the cuff into the glove. It's still fine to use that type of garment, but you should be extra diligent with your hand and arm hygiene after you've completed your procedure. They're primarily reusable, made out of cotton and synthetic fiber. As such, they should be used when you're doing AGP procedures. They should be doffed and placed into a linen bag, and laundered and used only for one procedure. So next I'm going to talk about eye and face protection. So again, face shields, something that some of us may be familiar with. Again, depending on the nature of our practices, some may not be quite as familiar. Essentially what it does is provide a barrier for the entire face to aerosols, droplets, and splatter that may be generated during the provision of dental care. They're very comfortable to wear. However, they do lack a peripheral seal. This can vary based on manufacturer. So again, if you're going to purchase, if you're in the process of purchasing face shields, you should look specifically at how much side protection, in other words, how much it wraps around the side, as well as the length, which is variable between manufacturers. So you want a fairly long face shield to protect as much as the face and neck area as possible. A mask with a visor can be used for non-aerosol generating procedures. Again, face shields are typically reusable or disposable. Reusable versions obviously need to be disinfected and reprocessed. And again, within our guideline, there's instructions on how to properly reprocess face shields. So moving on to goggles, again, differ from a different piece of protective equipment than a face shield. So again, it forms a protective seal around the eyes, which prevents droplets from entering around or under them. They have the disadvantages that they do not provide splash or spray protection to other areas of the face. They tend to fog, and they can be quite uncomfortable with extended use. Again, they're typically reusable, and as such, they should be reprocessed and disinfected according to the information contained within the guideline. So lastly is safety glasses. So obviously the least protective of the three items. Loops with side extensions would be an example of a acceptable safety glass. They should only be used if higher access to a higher level is not available. Within our guideline, if you read through it, the recommendation is for AGPs at present to use either a face shield or a goggles. Now, people that use loops, depending on the type of face shield, there are face shields you can buy that will you can use over your loops. I use a headlight when I operate, and I was able to find a face shield that would accommodate my my headlights. So again, keep that in mind when you're purchasing face shields. The take-home message from eye face protection is that it must protect the eyes of the dental healthcare professional from splatter, droplets, and aerosols generated during the provision of dental care. So again, it's left up to the discretion of the dental healthcare professional as to what type they choose to wear.
So just a quick bit on gloves. Not a whole lot has changed with respect to gloves, nor should it. We've always done an appropriate job of this. Just want to point out a couple of things. As Curtis alluded to, if the gloves don't go up over the cuff of the gown or lab coat, just keep in mind that a little extra special attention to that gap that could potentially be between where the glove ends and the gown or lab coat starts when it comes time for hand hygiene. The other thing to point out that there were some questions early on regarding is that certainly a single pair of gloves is absolutely okay. In some of the hospital-based donning and doffing guidelines, you'll see recommendations with respect to the outer glove and then the inner glove. And that's not to suggest that you need two pairs of gloves. Just in the hospital for a lot of the surgeries that we're doing, certainly anytime we fix a fracture, for instance, we wear two pairs of gloves just because there's a high chance of ripping and tearing. But that's not to say you need that to carry on your routine care like you normally do. It's simply they do the two pair of gloves and show how to take off the two pair of gloves so that that guideline is applicable to the person looking at it. So donning and doffing, certainly lots of ways to get this right and wrong. Certainly the emphasis needs to be on getting doffing done properly. So when you're putting on clean PPE, I say the stakes are relatively low there. Certainly if you're starting from scratch, you would start at number 2 here, hand hygiene. Put on your gown, then apply your mask or your respirator, followed by your face and eye protection, and last but not least, your gloves. Moving on to doffing, I say the more important of the two. You would want to start by removing your gloves, and this is where they'll say glove to glove, skin to skin. So if you're wearing a single pair of gloves, you're going to take one glove, grab the wrist of the other dirty glove and take it off. So now you have one free hand. Then you can use the skin to skin, where you basically reach under your glove that still remains on your other hand and remove that glove. You can imagine that in doing so, you could have potentially contaminated your hand as you kind of found that little tunnel between your gown and your glove. So that's why they recommend hand hygiene between most of these steps, just so that you're going on to the next step with a clean set of hands. So remove the gloves, glove to glove, skin to skin, hand hygiene. Then you can take your gown off. Once again, you can imagine in doing so, you could potentially contaminate those hands. So hand hygiene once again, followed by removing of your face, eye protection, and mask. Moving on to aerosols. So a lot of work left to be done with respect to aerosols and dentistry and in the rest of medicine, to be honest. There's still a lot of work to be done as far as what's clinically relevant. But the definition of an aerosol used here would be simply the suspension of tiny particles or droplets in the air. Now, we know that these can be produced anytime an air current moves across the surface of a film of liquid, generating these small particles at that air-liquid interface. So therefore, if a procedure causes air to move at high speed over the respiratory mucosa, epithelium, or saliva, then production of aerosols can occur. Next slide. And that's where that term AGP, you'll see AGMP, the M is for medical, so certainly AGP is used a lot more in dentistry and seems to be getting used a lot more in medicine as well. So AGP is just an aerosol generating procedure. So defined as any procedure that can create the production of these aerosols of various sizes, including what's known as droplet nuclei. So within dentistry, how does that apply? So certainly three-way air-water syringes, ultrasonic devices, high-speed, low-speed handpieces, lasers, microabrasion or air polishers, basically anything that rotates has the potential to make these aerosols, certainly droplets and spatter. Within this, there's obviously going to be a range. All these are not created equal. Clearly, a slow speed would create more than a high speed, but certainly work to be done. Why does that matter at a time like this? Well, at a time like this, as an added layer of protection, if you have a patient that is COVID positive or symptom or risk factor positive, and they need a procedure which involves an AGP, that's why we're recommending it be referred to a clinic where airborne precautions can be recognized. So this is the table straight out of the guideline, which was recently sent around. So most people would have had a chance to look at it, but you can certainly go down and kind of see where you fit in and what procedure you're doing, which type of PPE would be required for that procedure. So, so for a dental healthcare provider performing a non-AGP surgical mask, eye face protection, scrubs and gloves is sufficient. If you're doing an AGP, then a fit tested N95 or alternative. An alternative would be face mask and full face shield, as stated in the guideline, is perfectly acceptable alternative. In addition to your eye face protection, gown or lab coat, and gloves. For disinfecting the rooms, the PPE is similar to what's required for doing the procedure with some minor changes. You can see for disinfecting after a non-AGP, surgical mask, eye protection, scrubs and gloves, and after an AGP, surgical mask, eye face protection, gown and gloves. We want to minimize visitors unless it would absolutely be necessary, depending on the patient's unique situation. For front office staff and reception, either a protective barrier around the reception desk or a surgical mask would suffice. You certainly don't need both, but you certainly could do that if you so choose to, but it's written as a or intentionally. And to maintain spatial distance at least 2 meters when possible. And important that it says when possible, because in certain circumstances, that's not possible. I'd like to introduce our next speaker. It's Miss Marina Crawford. She is a RDA and a member of the board.
Thank you, Dr. Brady. Good morning, everyone, and thanks so much for joining us. The last 10 weeks have been very stressful for all of the dental healthcare providers. Many RDAs and also RDHs are worried about the unknown because in this environment, we have nothing to compare it to. As dental healthcare professionals, we are very adept at being one step ahead, and one step ahead may be an understatement. We are perfectly capable of adapting to the changes being brought forward in this document because, as we all know, we can have a plan change 3 times on one patient in one appointment, and we don't blink an eye. So with that, I'll go over some of the protocols that will be in place regarding infection prevention and control. So we're recommending and encouraging everyone in their time away from practice to review the NSDA Infection Prevention and Control Manual. All of us as registered dental assistants and registered dental hygienists already have an excellent foundation in infection prevention and control. Our educational programs have assured that. We are suggesting the review of the document as a way of getting everyone back in the return to practice mindset and refreshing ourselves on best practices. So ensuring cleaning staff are fully versed on enhanced cleaning protocol for COVID-19. Just make sure that attention is being paid to frequently touched surfaces, doorknobs, light switches, sink taps. Cleaning doesn't necessarily kill germs, but by removing them, it lowers the risk of spreading infection. Regularly disinfect high-touch surface areas in the waiting room, front desk, and staff room. Just make sure that it's Health Canada approved. This is going to require a team approach because most front desk staff won't have an extensive knowledge of infection prevention and control. So helping to familiarize them with disinfection procedures and making sure that they're aware of the contact times for the product to be effective. Emphasize hand hygiene. That includes hand washing and hand sanitizers. So the minimum hand washing time is 20 seconds, and for hand sanitizers, following minimum times recommended by the manufacturer. And the lid must be kept on the ultrasonic cleaner in the sterilization center. And I know this is a given, but it's just a little reminder. It just helps control the spread of aerosols in your sterilization center. And clearing your operatories, that means countertops and open shelves of all items other than those necessary for treatment. So only essential supplies and equipment on countertops, and also making sure that all the supplies that are needed are present in the operatory. And dental healthcare professionals must practice social distancing when possible. Again, this is going to require a team approach. We may need to stagger lunch and break times, and depending on how large your sterilization center is, it may need to make sure that you're wearing proper PPE, including masks. Healthcare workers wearing proper PPE do not have to follow the 2-meter social distance rule, but we're quite adept at working as a team when it comes to that stuff. Oh, there was one more there. Water lines must be purged for at least 2 minutes at the beginning of the day and at least 30 seconds between patients. And handpieces must be removed from their couplers and motors, and air water syringe tips must be removed before purging with water. And next, I would like to introduce Dr. Neda Haidar, and she will review the NSDA Return to Practice document.
Good morning, everybody. I'd like to welcome you all here. A huge thanks goes out to the Provincial Dental Board for generating the guidelines out of their Phoenix Committee. The communication between the Phoenix Committee and our committee at the NSDA was unprecedented. The guidelines changed frequently throughout, but with the continued communication between all of us, we were able to generate an office manual. Next slide. The manual is intended to be used in conjunction with the guidelines. So when you look through the manual, you'll notice that it's set up with checklists and flowcharts. It's very easy to follow, but all of the guidelines are built into the document. We did look at the CDA Return to Practice document as well, and we noticed that there were some areas there that complemented our guidelines beautifully, so they're also included or built into the manual that we have. The manual does start and open up by saying that it must be personalized to your own clinics by the occupational health and safety standards. So we would appreciate that when you are using the manual and the guidelines to train as a team, you do keep it in mind that you have to decide how to make it and the guidelines work within your practice. The document is considered fluid. That means that it can change, and as we know, things change frequently with COVID. So it will be amended and reissued as needed. And again, I would be remiss if I didn't thank my NSDA Return to Practice advisory group. We put in many, many hours, and we put a lot of thought into the manual, thinking of all of our members and their teams and how we could set something up so that the manual would really help them install the guidelines in their offices. Next slide, please. So the manual has different sections. If you look through it, it's organized quite nicely. It might seem a little bit repetitive, but that is that's there for a reason. It's just to reinforce a lot of the very important guidelines that are in the that came to us from the board. There is an office checklist and a team checklist. There are checklists to help you before the appointment, during the appointment. Obviously, there'd be a glossary of terms and acronyms, and there are different flowcharts built throughout the manual. One of them is the patient treatment decision tree. It just kind of makes it easier for the whole team from the front to the back to recognize how patients can flow through a day. There are many resources in the document as well. We have a return to practice checklist. There are screening forms and referral forms, and of course the donning and doffing pictures that Dr. Brady showed are also in there. Everything is printable, so you can print posters, donning and doffing PPE posters, put them where they're needed. It's really a manual that's designed to help the team get the office ready. We're proud of our PPE shopping list. We do preface it very strongly with our members going to their dental suppliers. They are the trusted source for PPE. However, we do understand that some dental suppliers are a bit behind or do not have some of the PPE that we require. So the PPE shopping list does have some very creative places and businesses that we wouldn't normally call where we can get some of our PPE. And again, the office posters are all in there, from cough hygiene to screening, symptoms that you can put on your front door. So we're hoping everybody really finds it quite useful. Next slide, please. Again, those are the donning and doffing that can be printed and put up in your operatories. The flow chart above it was created by Dr. Scott McLean and Dr. Michelle Camo. And again, that is the chart that I was talking about, where when the patient calls all the way to when you are when you have them seated in your operatory.
Thank you, Dr. Haidar. I'd now like to call on Dr. Joanne Thomas, to provide the president of the Nova Scotia Dental Association, to provide some closing remarks. Dr. Thomas.
Thank you, Don. On behalf of the NSDA, I would like to thank all of our panelists today who participated. Countless hours have been put into bringing these resources to this level, and these are unprecedented times in our global world, and the remarkable collaboration on every level in our oral health care world has been demonstrated here today. The NSDA would also like to express appreciation to our members for their commitment to the public's oral health emergency needs during the pandemic and for their patience. We trust that these resources and webinars will help you in the days ahead. Based on the exchange of information here today and yesterday, we realize how important staying connected is. Now, more than ever, it is vital to be up to date with the new changing landscape in dentistry. I'd like again to thank our moderator, the panelists, and all of you, the participants. And I wish you all the best in your return to practice. Back to you, Don.
Thank you. We're now moving to the question portion of the webinar. We'll be answering questions until approximately the next half hour, until about 12:30. In addition to all the presenters that you've seen today, Dr. Martin Gillis, the Registrar of the Provincial Dental Board, is also available to answer questions. Again, many questions have already been submitted by chat, but if you'd like to submit a question, please do so with the chat function on the Zoom app. For questions that we do not get to today, the board will be posting a series of frequently asked questions on its website in the coming days, and we will certainly try to capture the essence of all questions that were submitted that we don't get to. Okay, so the first question will be for Dr. Gillis. Dr. Gillis, there have been some concerns that the return to practice for dentistry proceeded despite some concerns that were raised by the Nova Scotia Dental Assistants Association. Could you just comment on that and provide some perspective on the return to practice?
Well, the Phoenix group that was constructed for the return to practice had a registered dental assistant as a member of this core group. There was also a stakeholder advisory group which was comprised of all of our stakeholders, including the Nova Scotia Dental Assistants Association. The NSDAA president sat on this stakeholder group. The Phoenix group provided the draft guidelines to the stakeholder advisory group, and the NSDAA did provide feedback. The feedback was centered on providing extra guidance regarding the purging of water lines, and that registered dental assistants should be reviewing the NSDA IPAC guidelines. Those recommendations were incorporated into the final draft of the return to practice guideline, which was sent to the Chief Medical Officer of Health, as well as all the stakeholders. On May the 15th, there was a conference call with the Chief Medical Officer of Health and all the stakeholders, which involved the regulated oral health professions, dentistry, denturists, the dental technicians and hygienists, as well as the member services organizations, so the NSDAA and the NSDA were on the line. And at that time, the NSDAA did provide additional concerns with the guideline that weren't expressed in their stakeholder feedback. Dr. Strang at that time suggested that all the organizations that were on the call provide letters of support of the guideline. And if they didn't supply that support, that what they would have to do is to provide their own guidelines for return to practice. All four regulated health professions, dentistry, hygiene, technicians, and denturists support the return to practice guideline, and have, since that time, have been developing the oral health regulators return to practice. The NSDA signed off on it, but the NSDAA did not sign off, nor did they provide an alternate plan. This plan has been moving forward and is now in the hands of the Occupational Health and Safety, as well as Dr. Strang, and will eventually be approved by Department of Health and Wellness, but we're very close. But all along, the NSDAA did have the opportunity to provide feedback, and an alternate plan wasn't presented, and the regulators have proceeded, and we're getting very close to final endorsement of the guideline.
Thank you. The next questions will be for Dr. Brady. Dr. Brady, there have been a number of questions about the lack of settling times after AGPs in the document, as well as questions about proper HVAC protocols. So could you maybe address that, settling times after AGPs and HVAC recommendations, if any?
Yeah, absolutely. It's a great question. And it certainly isn't an oversight. It's been a lot of time and thought put into the recommendations so that they're evidence-based. When referring to settling times, that is something specific to recognizing airborne precautions and typically reserved for airborne pathogens that are primarily spread through that route. So something like pulmonary TB or measles. The CDC, certainly in the most recent update, May 19th, states very clearly that SARS-CoV-2, the pathogen, the virus responsible for the disease, COVID-19, is primarily spread through respiratory droplets. So that's why the guidelines and the recommendations read the way they do, with surgical mask, full face shield, gown, gloves, which is in complete parallel with a guideline respecting contact and droplet precautions. With respect to HVAC, once again, there's certainly no required minimum air changes per hour, or ACH. So with respect to HVAC, essentially you want to appeal to Occupational Health and Safety Nova Scotia guidelines for HVAC, which recommend regular maintenance and making sure it's working properly and changing filters regularly.
Thank you, Dr. Brady. The next question will be for Dr. Gillis. This question was submitted. Dr. Gillis, non-registered dental assistants are being employed in dental offices as opposed to RDAs. I am concerned this is putting patients and staff at risk. Can you address the role of non-registered dental assistants?
Thank you, Don. Well, dental offices have workers that provide care that are both regulated and unregulated. The regulated dental healthcare providers are dentists and registered dental assistants who are registered and licensed by the Provincial Dental Board of Nova Scotia, and dental hygienists who are regulated and they're registered and licensed by the College of Dental Hygienists of Nova Scotia. At the same time, there are unregulated care providers. You would see them as front office staff and unregistered dental assistants. It is important that all regulated dental healthcare providers work within a scope of practice. For those areas that aren't within scope, dentists can assign and delegate care to unregistered care providers. And this would include infection prevention and control, as long as it is done with the direct supervision of a dentist. The Nova Scotia Regulated Health Care Providers Network has a guideline for delegation and assignment for care providers who are not regulated, and these can be found on the Dental Board's website. So this is something that can happen, and it's done in a proper way, and there are guidelines on the board's website that would allow this to happen.
Thank you, Dr. Gillis. The next set of questions are going to be for Dr. Gregoire. Dr. Gregoire, we've received a number of questions about caps on numbers. So specifically, is there a cap on the number of personnel that can be in a dental office or be working in a dental office when we return to practice? And is there a cap on the number of patients that can be in the waiting room or in a dental office at any one time?
Thank you, Don. So to answer the first part of the question with respect to dental healthcare professionals, There is no absolute number of office staff that can be in the office at any one time. There should be a sufficient number to perform procedures which are scheduled for the day. During the provision of dental care, as we all know, it's impossible to maintain physical distancing, and that's why we're recommending all office staff wear masks even when they're not providing direct care for patients. Because again, it's not always possible to physically distance, so that recommendation was included to wear masks even when you're not treating patients. With respect to patient numbers, again, the number of patients in your office at any one time, you should try to keep it to a minimum. That said, the waiting room can be used as long as they're observe social distancing. Again, we're encouraging patients to bring their own mask, either surgical or non-surgical masks, to their appointments. And again, there's no absolute number as long as that 2 meter, 6 feet distance between patients can be observed, and your waiting room is set up appropriately and disinfected on a regular basis.
Thank you, Dr. Gregoire. Dr. Haydar, maybe I can just get you to build on that a bit. There are a number of multi-dentist practices. So in your return to practice guidelines, what should multi-dentist practices do in terms of number of dental office personnel or number of patients in the office? You're on mute, Dr. Haydar.
Again, I refer back to exactly what Dr. Gregoire said. As many personnel as it takes to run your dental office for that day is how many would be in there. Of course, when they don't have their PPE of mask on, they should observe social distancing, for example, in the staff room. But as long as they have their mask on, they can coexist with each other in the dental space. As far as patients go, your waiting room needs to be socially distanced in chairs. You can have patients wait in their cars until they're called in if you do not have the ability to do that in your waiting rooms. When they come in, it's my understanding from the guidelines that you want to minimize the amount of time that patients are actually in the space. So just be very efficient bringing them in and in their exit.
Thank you. The next question will be for Ms. Crawford. There are a number of comments about what should be done by dental assistants if their dentist or their employer is not providing them with the proper PPE as outlined in the return to practice document or plan, as well as in the return to practice guidelines from the NSDA. So if a dental assistant is not receiving the proper PPE, what would you recommend?
Thanks, John. So all employers are obligated to provide a safe working environment, including providing proper PPE. So I recommend first meeting with your employer and trying to keep the lines of communication open. But as a last resort, you can contact the Provincial Dental Board.
Thank you. Dr. Brady, there were a lot of questions in the chat on masks. And I know you went over this in your presentation, but perhaps you could just once again talk about the degree of safety of a face shield and a level 3 mask versus an N95. There are a lot of questions about that. So maybe just touch on that. Are face shield and level 3 mask acceptable and safe for AGP procedures?
Yeah, so understandably, a lot of questions associated with that. One of the things, of course, to keep in mind, as Dr. Gregoire pointed out, is that PPE really is at the bottom of the pyramid as far as ways to keep you and your staff and your patients safe. You know, a lot of work can be done with appropriate screening when booking patients upon arrival, as well as all the other modalities outlined in the document with pre-procedural rinses, suction, etc. With respect to the masks themselves, So certainly, when we review the literature, we see papers like Radonovich, as well as systematic reviews like the one I mentioned by Long et al. There was one I didn't even mention because it was a little bit older, 2016, which found the exact same findings. I chose to review Long et al. Because it was the newest. It incorporated the most prospective RCTs. And I say these are very well done studies in a prospective randomized controlled fashion. Once again, showing that clinically there was no greater risk to the healthcare worker when wearing a mask, surgical mask, versus a fit tested N95 with respect to developing clinical influenza-like illness or serology confirmed seroconversion from contracting it while working on these patients. I say the Radonovich one specifically was very well done. Would be very hard to repeat as well, just because it was done over a 4-year period of time, very high cost, very high number of healthcare workers involved. I think I said it was 2,862 workers involved in that study. So fantastically done study, and important to have these studies, because if we just rely on, a benchtop study comparing, product A to product B, these things can be misleading. We want to know is what is important, clinically, what makes a difference clinically when we're working on these patients, making aerosols, making droplets and spatters, and what can we hang our hat on from a safety perspective. So I think we're fortunate that these studies have been done. I think it would be nice if we could replicate some of these in a dental specific setting, but I can appreciate that will take many years to do, just looking at the complexity of the study that was done. As I will point out in the Radonovich paper, that the majority of these procedures that were being done were considered in that high risk category, which is sort of where dentistry would fall under, and dental office, some dentistry was involved in that study as well, but it wasn't just dentistry. It was many different facets of healthcare. And it was very interesting to see those findings, and informative. So if we want to move forward in a safe fashion, in an evidence-based fashion, we really do have to look at literature like this and respect it, and move forward in an evidence-based way. Once again, recognizing that this is only a component of the protection that we're providing for our staff, ourselves, our patients. This is only one layer of a multi-layered approach.
Thank you. The next question will be for Ms. Crawford. I think you touched on this in your presentation, but we did get a question, so I'll just ask it. Ultrasonic instrument cleaner puts aerosols in the air. What should I do to address this?
So yeah, keeping the lid on the ultrasonic cleaner, the machine that you put your instruments in, is the best way to control the aerosols there.
Thank you. Dr. Gregoire, there were a number of questions on screening of staff. So I'm going to ask you to go over the screening of staff just briefly, but some of the questions are, do I have to take temperature of staff every day? Do staff have to get COVID-19 tests? As well as, what should a staff person do or an office do if in the unlikely situation or unfortunate situation, a staff member does test positive for COVID-19?
Okay, so there's a few questions in that question. So first of all, do we need to be tested before we go back to work? The answer to that is not, unless you have any of the symptoms of COVID-19. Certainly when you go to work in the emergency dental clinics, we're not tested prior to going into to work in any of those clinics. That said, we do use the screening tool for healthcare professionals, which is included in the appendix in both the PDBNS document, as well as in the NSDA document for daily screening. So again, If a staff member fails their daily screening, then they should not come to work, obviously, and be directed to 811 to arrange for testing.
Thank you. The next question is for Ms. Crawford. My office has a small sterilization center. How are we expected to social distance in that environment?
Thanks, Dawn. So wearing a mask, if you can't maintain proper social distancing, is probably the best thing. Healthcare workers wearing proper PPE do not have to follow the 2-meter social distance rule.
Thank you. The next question will be for Dr. Gregoire. Can your gloves be sanitized with hand sanitizers?
I suppose anything's possible. I don't think that would be the best practice to try to reuse your gloves by hand sanitizing. I'm not aware of gloves being at critical supply issue, so my suggestion would be not to attempt to reprocess gloves. Use them as a single-use device and discard them after each patient encounter.
Thank you. Dr. Gillis, the next question will be for you. Will the Nova Scotia College of Dental Hygiene be issuing any different or additional reopening guidelines for their members?
As noted, the 4 oral health regulators are developing a sole document that will be provided to all registrants. Each college will have a section devoted to their own registrants. They are registrant specific, so for the most part, the guidelines are very consistent, but you might see more differences, for instance, between dentistry and dental technicians, or dentistry and denturists. But the guidelines and documents for hygiene and dentistry are quite similar.
Thank you. Dr. Haydar, there's been a request, a question about where they can get access to your documents. And maybe with that, you could just talk about how individual dental offices can maybe utilize the board's plan and your document to make their own individual return to work plans.
Our manual was sent out to all of our members once the Provincial Dental Board released the guidelines. Dentists have access to it. Everybody received it by email, and it's also available on the NSDA website. If you go in, there's also a COVID section on our website, and it's very easy to access it through there as well. The manual is specifically designed to help with workflow. So from the minute the patient phones the office, there would be checklists on how to screen them, and then a flow chart on, for example, let's say they answered 2 screening questions in the positive. There's a flow chart that directs them what to do with that, or even if they answered 1 risk factor positive. And then screening happens again. So if you read through the manual will step-by-step guide you on what to do from the minute a patient calls to the minute they enter your office, all the way to the end of the appointment, all in checklist form and repetitive, so that the entire team can get it right from start to finish. I hope I answered that question.
Thank you. The next question will be for Ms. Crawford. It's a little bit long, so bear with me. Several dental devices that contact mucous membranes are attached to the air or water lines of the dental unit, including high and low speed handpieces, ultrasonic and sonic instruments. These devices have the potential of becoming contaminated. What are the protocols with respect to these devices?
Thanks, Dawn. My reply will be a little bit long as well, so I'll try to go slow so everybody can absorb what I'm saying. Yeah, several dental devices that contact, such as high and low speed, they do. These devices have the potential of becoming contaminated by retracting oral fluids into their internal compartments. And these fluids can be then expelled into the oral cavity of another patient during subsequent use. So in order to flush out any patient material that may have entered the turbine or air and water lines, these devices should be activated to discharge air and water for a minimum of 20 to 30 seconds after each patient use.
Thank you. The next question is on a treatment procedure for Dr. Walsh. Patient has a chipped front tooth and wanted some bonding put back on it. Is this a procedure that would be allowable after June 5th, or should it have to wait until June 19th?
Thanks, Don. So that would depend if it was a urgent or non-urgent procedure. So if the patient, the chipped tooth was causing pain, sensitivity, cutting the lip, then certainly that would fall under the urgent category. And this can begin June 5th. If it was asymptomatic and just an aesthetic concern, then unfortunately the patient would need to wait till phase 3, and we're hoping to start that on June 19th. So no dental office would be permitted to provide non-urgent care until June 19th.
Thank you. I guess, Dr. Hayter, I'll direct this next question to you. It's about waiting rooms. Do we need to remove all chairs from our waiting rooms, or just enough to observe social distancing?
You would remove just enough to observe social distancing, and remember it is part of the guidelines as well as embedded within the manual to remove any touch items like toys, remote controls, magazines. Those all have to go.
Next question is a very technical question. It's regarding the consent to treatment form. So I'll initially, I guess, throw it to Dr. Gregoire, but maybe someone else can answer it, one of the other panelists. In the consent to treatment form, it lists people over 60 as a risk factor. Two-part question: why was 60 chosen? And more importantly, are we supposed to put off treating people over 60?
Okay, so the first part of the question, why were patients over 60? That was based on, that's a public health figure or age based on literature, as far as I understand. The second part was should we treat them? What was the second part of the question? No,
Yes,
but
should patients over 60 be treated?
Yeah, so I think both the PDBNS document and NSDA document speak to some considerations for that specific patient population, not just based on age alone, but also on comorbid medical conditions. So booking them first appointments in the morning, first in the afternoon, end of the day, or having set days for that specific cohort of patients are reasonable things to consider.
Thank you. Next question is for Dr. Gregoire as well, regarding gowns. Can we wear the protective gown when we leave the treatment room? For example, assistants going to get radiographs.
So again, it depends on what type of treatment you're performing with the gown on, okay? So if you're not performing an aerosol generating procedure, then it's not soiled, nor has the patient coughed on it, it's completely acceptable to walk out of the room with your gown on. Another consideration, so in the clinics that I've worked in, we have additional staff. So should some piece of equipment be required, and the assistant and the operator are donned with all our protective equipment to have somebody outside that can readily access or get equipment that may be required that might not be in the room. So that's another consideration to keep in mind when you're each office is designing their own back to work action plan that's specific for your office.
Thank you. Ms. Crawford, I'll direct this next question to you. It's regarding cleaning protocols. What special cleaning needs to be done at the end of each working day? For example, do floors need to be mopped? Currently, our cleaner only comes in twice a week.
Thanks, Dawn. So beginning and end of the day of wiping high-touch surfaces would be a good idea, as well as several times during the day.
Thank you. I'm going to ask Dr. Albert to take the first shot at this question, and maybe another panelist, if they want to address it, can put their hand up. I would really like to know how I can safely use ultrasonic instrumentation.
So ultrasonic instrumentation, I guess the basic guideline would be that we're trying to minimize AGP, so that would fall under the AGP procedure. But if you are going to use an ultrasonic device, make sure you have the proper protective equipment and doing it on patients that have been screened, and you're using all the other layers of protection that we're advocating, such as a pre-rinse for the patient, rubber dam use, all the things that you can do to minimize risk and minimize the use of it if you can. But sometimes it will be required.
Thank you. I'll direct this next question to Dr. Gregoire. What pre-procedural rinses, excuse me, are recommended to use? Is chlorhexidine ineffective?
So I haven't read any literature suggesting the use of chlorhexidine. The two, which I think everybody's seen most commonly, would be hydrogen peroxide and betadine or providine iodine solution. So I'm not familiar with any literature around chlorhexidine. I'm most familiar with the two other products, which are listed in the guideline.
Thank you. The next question will be for Dr. Brady regarding aerosol generating procedures. You mentioned avoiding AGP, so drilling is allowed when needed. Is drilling allowed when needed in, I guess, phase 2, the June 5th to 19th phase?
Yeah, absolutely. The nature of it is to have a staged reboot to practice, and where the option exists to not create an AGP, then that is encouraged. For instance, in our practice, that happens all of the time. Certain instances where maybe I would take a 701 burr and drill a root out. Instead, I'll use another modality that's a non-AGP at this time, like a cryer, to remove that root. So that's just a specific example of a workaround that that I can use in my practice instead of maybe doing what I would routinely do. But if it involves, somebody with a symptomatic cavity, dental caries that requires drilling, then that's required for that. So it's certainly not an absolutely do not do AGPs. It's just if and when they can be avoided to do so. But if you need them, you need them. And the PPE requirements are clearly laid out in the table for when you do need them.
Thank you very much. The next question will be for Dr. Gregoire, and it's regarding lab coats. We've gotten a number of questions about this. Previously, we wore lab coats until visibly soiled. Would we now have to change coats for each patient?
So again, as I've mentioned earlier, certainly it's in the context of the procedure you're doing. And again, you have to use your clinical judgment like many of these things. This is a guideline. So obviously, if you're doing an aerosol generating procedure, you would expect the linen to be soiled, if not visibly. You would expect there to be some contamination of the garment. So yes, after aerosol generating procedures, it should be doffed, and as I alluded to in my discussion, disposed of in an appropriate receptacle, depending on whether it's reusable or disposable. Again, so when you do a non-aerosol generating procedure, so if you're doing a quick check on a patient, for instance, a lab coat's not necessary. So you can do a quick check, and it's not necessary to don a lab coat. So again, if you're doing invasive treatments such as extractions, even if you're not anticipating using a drill, then I would recommend using your lab coat and again, doffing it and using it only as a single use for procedural issues.
We only have time for a few more questions. This next question, I'll go back to you, Dr. Gregoire. It really deals with the screening protocols. So a couple of questions here. What if people say that some of the symptoms are just due to allergies? What if they're taking fever-reducing medication? What if people lie on their screening protocols? Can you maybe, I can repeat each one of those as we go, but maybe just address some of these scenarios?
Okay, so the first one was, what was the first part of that?
So what if they say they have symptoms, but they're due to allergies, running nose?
Well, so again, if they screen positive using that tool, then they're not to be scheduled. They should be directed to call 811 and arrange for testing. And again, if it's a true emergency, then they should be referred to a clinic that has the ability to offer airborne precautions. If a patient lies on a form, I don't know I don't really know how to answer that. Certainly there's a consent form, and the idea with the consent form is they're making a declaration that they're honestly answering your questions. Certainly when they show up, if they have any signs, even if they've suggested that they have no signs or symptoms, if they look ill, then I wouldn't allow them into my facility.
Did you want to expand upon that a little bit, Dr. Gillis, in terms of lying on the consent form?
Well, I think, in light of what's going on in Campbellton, I think it's important for not only with patient screening or it's also with staff that everybody is honest in how they respond to the questions when it's a patient or for a staff member when they're reporting to work. I would imagine that if there is a violation that's uncovered, that it would be reported to the Chief Medical Officer of Health, and it would be taken from there. I think these things are very serious matters, and if an individual was having COVID and wasn't disclosing this properly, that this could seriously impact that individual.
Thank you. Last question regards symptomatic patients who have true emergencies. They need to be referred to a facility that have airborne precautions. Is there a list of these types of facilities, Dr. Albert?
To my understanding, it's not. There isn't a list. So if I'm correct, it's going to be limited to people that have true emergencies that are testing positive. So you have to refer to a clinic that can maintain airborne precautions. I know that the oral surgery department at the VG would be one of those sites. And I'm not expecting the 8 emergency clinics to continue to offer that kind of service. So I think the best advice would be to phone around to see if anybody has closed rooms that have that capability, and make the dentist to dentist contact first to find out if those patients can be accommodated at certain clinics. So as of yet, I don't have a list of those clinics. It's something that we can look into possibly.
Thank you. Well, there were a few questions, quite a few that we were not able to get to. As mentioned, we will be posting a list of frequently asked questions on the Provincial Dental Board site. I'd like to invite Dr. Martin Gillis, the Registrar of the Provincial Dental Board, to close today's webinar.
Thank you, Don. So I do have some closing remarks. Thank you for attending today's webinar. The board hopes that the sessions held yesterday and today will help you with your return to practice when offices start to reopen on June the 5th. The board offers its sincere thanks to the Faculty of Dentistry, Dalhousie University, the Department of Oral and Maxillofacial Surgery, QE2 Health Sciences Center, and the Nova Scotia Dental Association for developing and delivering the webinars. The board would also like to thank the College of Dental Hygienists of Nova Scotia, the Denturist Licensing Board of Nova Scotia, and the Nova Scotia Dental Technicians Association for their great collaborative effort in the development of the Return to Work Guideline for the oral health professions of Nova Scotia. The board's guideline reviewed yesterday and today is a component of this document. It is anticipated that Occupational Health and Safety Nova Scotia, the Office of the Chief Medical Officer of Health, and the Department of Health and Wellness will give final approval very soon. The Provincial Dental Board will work with the oral health regulators to update this guideline as directed by the Chief Medical Health Officer and evolving best practices. In addition, the board will be posting frequently asked questions on its website under the COVID-19 tab in the days and weeks to come. And finally, I personally want to thank the members of the board's executive group for the work that it has undertaken over the past 11 weeks. It's an honor and a pleasure to work with you all. Thank you, everybody, for attending today's webinar, and enjoy your weekend.
So we now will go to the question portion of today's webinar. In addition to the presenters, Dr. Martin Gillis, the Registrar of the Provincial Dental Board of Nova Scotia, will also be available to answer questions, as will, of course, Dr. Thomas and Dr. Albert. I will moderate the questions. As I said, we have received some questions through the chat function that I will read, and we will go till approximately 2:30. If we do not get to questions, all of the questions that were submitted, there will be a list of frequently asked questions that will answer all of the questions that were submitted on the list that will be posted on the Provincial Dental Board website in the coming days. So the first question, we received a lot of questions, Dr. Gregoire, on coats and gowns and donning and doffing. So if people are to leave the office, are they required to doff their gowns when they leave and put on new fresh gowns when they come into the office? If they're leaving for a smoke break or for lunch, are they required to don and doff their gowns?
Yeah, well, to start with, they shouldn't be going out for a smoke break. But that aside, if you leave your office, then you should definitely remove your set of clothing that's dedicated for to wear in your office. So scrubs would be an example of that. But everybody should have a dedicated set of clothes that they wear within the office. And if you leave the office, they should be taken off and street clothes put on to leave the office. When you come back, you can put your same office, dedicated office clothing on, change it if it's visibly soiled, but otherwise you can use the same office dedicated clothing.
Thank you. The next question, we received a number of questions on this topic, Dr. Hayter. Will we have to stagger our appointments when we return? During a normal 10-hour shift, I would receive anywhere from 12 to 15 patients a day. What can we expect on our return to practice?
I think that the importance of realizing that you need to maintain the level of traffic in your office to be able to keep social distancing a possibility in your public spaces, like your waiting room and hallways. You might want to look into staggering. I'm not sure how that would look. However, if you took a patient into the operatory, if you had 4 operatories and they were all entering and leaving with the possibility of social distancing being maintained, I'm pretty sure there's not a real number.
Thank you. The next question is for Dr. Albert. If there is a rise in cases in our province, how does the dental board plan on handling that? Will there be a plan in place to go back to emergencies only or to close dental offices again? Dr. Albert?
Thank you, Don. Yes, the plans were designed for this very eventuality or possibility. So the plans can be rolled from one level to the next very fluidly. So hopefully there's no rise in cases. The trend is certainly saying against that. But again, the situation in northern New Brunswick is quite worrisome. So let's keep doing everything we can to keep those numbers low. Overriding factor is we do have to follow the lead of our Chief Medical Officer. He's the one determining, what we can and can't do. He's going to set the stage as to what level of dentistry we should be doing, and we'll follow his lead and set the appropriate level accordingly. But we can roll from one phase to the next.
Thank you. Dr. Brady, we received a number of questions on settling times. The guideline does not recommend settling times. Could you just maybe go over that part of your presentation again.
Yeah, absolutely. So this is not an oversight. We spent many hours, thinking about this, looking at the literature, looking at what other provinces were doing, and putting everything together to make the right move forward. So certainly, COVID-19 is recognized by CDC as primarily being spread through respiratory droplets, as opposed to a pathogen that's primarily spread through airborne pathways such as pulmonary TB or measles. If we were dealing with an outbreak of secondary to a pathogen such as that, then absolutely the guideline would look different. So not an oversight. Certainly meant to recognize droplet-based precautions for our patients with all the PPE therein recommended. And only if you have a patient that has risk factors or symptoms do we recommend that extra level of precaution and likely either deferring the treatment or referring it, if it is emergent, to a place that can recognize those airborne-based precautions.
Thank you. Dr. Gregoire, the next question is for you. We received a number of these types of questions. We have, will there be limits on personnel in the office, so dental office personnel, including admin staff? Is there any relation to the 5-person limit that Dr. Strang speaks of, and any requirements on dental office limits?
No, so healthcare, provision healthcare is exempt from those rules, like the absolute numbers of people. We should have an adequate number of people to provide the care you need to provide. That said, it's nearly impossible during provision of dental care to social distance. So as a result, all dental healthcare professionals should wear a mask, even when they're not treating patients, when they're not able to social distance.
Thank you. I'll direct this question to you as well, Dr. Gregoire. Someone's written in that they have 12 operatories, 5 are closed. Should we plan to close in some more for aerosol generating procedures?
So again, we're not recognizing settling times based on the literature available at present. It's thought this is primarily spread via contact and droplet transmission. So no, you should treat the patient and disinfect the room according to the guideline, but there's no need for settling times or rotating operatories.
This next question is for Dr. Walsh. Can extensive caries be restored with regular restorative materials?
Thanks, Don. So again, I'll go back to the document, and it does define fairly clearly what dental emergencies are and what urgent dental care is. So if the patient has pain due to the caries, then it can certainly be restored with regular materials.
Thank you. Another question for Dr. Walsh, and you'll have to apologize, I don't understand the acronym. Is OSA urgent or non-urgent?
Thanks, Don. Before I answer that, I want to point out, I realize that I did neglect to thank one of our premier emergency dental clinics, Dalhousie University. So thanks, guys, for what you've done there. Dr. Chrisley and his team were instrumental in helping develop some of our guidelines. And I went and hung out with them one morning. It's an amazing job that they were doing. So thanks for your help, and my apologies for forgetting them. So again, obstructive sleep apnea appliances, I mean, typically they would not fit under urgent care. However, clinical judgment has to be used, and if the patient is in significant pain or there are reasons to justify that, like anything that we recommend, it is possible. So use your clinical judgment, look at the guidelines, and that should answer any question.
Thank you. The next few questions are on the screening protocol, so I'll be directing them to Dr. Gregoire. Dr. Gregoire, should works in a facility with outbreak be a risk factor under the screening protocols?
Sorry, could you repeat the question?
If someone works in a facility with an outbreak, is that a risk factor?
Yes, it would be considered a risk factor.
Next question is, now that the symptom list has been updated with the province, will it be updated within this document?
So as I alluded to earlier, we're using what's called a risk assessment criteria, which is specific for people seeking healthcare or oral healthcare. So it's a list of 6 symptoms and 3 risk factors, as opposed to surveillance swabbing criteria, which is the list of 11 signs and symptoms that's posted on 811. So that's intended to do screening. So it's casting a big net to try to find the proverbial needle in a haystack. So again, we're using a risk assessment criteria as outlined in the presentation and what's in the guideline.
Thank you. Dr. Brady, we've had a few questions on N95s and whether the appropriateness of other alternatives to N95s. So this is pretty typical of the question. If the recommended equipment is an N95 mask, why is it okay to use a lesser piece of equipment?
So the guideline reads that you can use an N95, but if not available, an acceptable alternative. So the guideline doesn't say that you have to use an N95. It's certainly a very reasonable option. And the reason why it reads an acceptable alternative is recognizing the literature that I reviewed with Radonovich, as well as Long et al. 2020, showing that clinically these devices perform very similar. So if you don't have N95s, it's absolutely acceptable to use surgical mask and a full face shield.
Thank you for that. The next question is more operational with respect to this webinar. So somebody has asked, can this presentation be made available for us to have and use with our teams? I would like to tell people that there will be another session tomorrow at 11 a.m. So please forward the invite to their teams and they can feel free to register for that session. We do intend to record the session, technology being what it is, and put it on the board website. So it should be available and up on the board website after tomorrow's session as well. Dr. Albert would like to mention something on that.
If I could just add that the CE credits are available for both sessions, regardless if you do one or both, you're available for both, and it's a good way to get free CE. Category 1.
Okay. Another good question. This is about masks for patients. If they bring their own masks in and are cloth masks, is their cleanliness of their mask an issue? So can patients bring their own masks in? Maybe I'll ask Dr. Hayter to maybe comment on that.
It does say in the guideline and is mirrored in the manual that you can suggest to the patient that they wear their own mask. And if they tell you they do not have one, you can give them a mask from your office.
Next question is, I'll read it, and it's regarding masks, so it's going to be going to you, Dr. Brady. What about wearing a level 3 surgical mask in conjunction with a 3D printed custom frame?
So once again, we intentionally don't get hung up on different levels. When you look at the medical literature, they group all of these masks together as surgical masks or medical masks, recognizing that they all perform a very similar level. So that's the first point. The frame, I've seen those frames. I like the idea and sort of the intent behind it as far as potentially improving the efficacy of the mask for what it's intended for. My understanding though was that was in a hope to maybe use as an alternative, an acceptable alternative to an N95. I know people have actually tried to get fit tested on them. I think for the most part, most people did not pass a fit test with that. So I don't think if you were in a situation where you needed to recognize airborne precautions, such as treating an emergency on a patient with COVID-19, that would not be an acceptable alternative. But certainly recognizing that a medical mask and full face shield is a acceptable alternative to an N95. Any variation between that, a level 3, a level 1, or 2 with a 3D printed frame is up to the provider to make that choice.
Thank you. Dr. Albert, we've received a number of questions on this topic, so I'll be directing them to you. People are worried about supply of PPE. Will there be enough supply of PPE for the return to practice?
Yeah, certainly that's the hot question of the day. I know that both the Provincial Dental Board of Nova Scotia and the Nova Scotia Dental Association have made contacts with government to see if we could supply or secure a supply of PPE. It really remains to be seen, Don. There seems to be alternative sources for PPE as well. The handbook that's produced by the NSDA with Dr. Hadar's group, it has got a list of places where we can find PPE, and that's very helpful. And they've got places that aren't usually in our usual shopping list. So you've really gone creative on it. And so with a little bit of creativity, I think you can find most things you need, but we are continuing our efforts to secure a steady supply from government if possible.
Thank you. Next question is just a follow-up questions on donning and doffing. Dr. Gregoire, does it matter where we don or doff, i.e. inside or outside the operatory?
Yeah, so I worked in 2 of the emergency dental clinics over the past 11 weeks, and we both use the same protocol. So we would doff just as we exit the treatment area. So we would pull our gowns off, dispose of them either in the linens or into a receptacle, as well as our gloves. After you take your gloves off, typically I would do hand hygiene and then remove my mask and dispose of it, and then obviously perform hand hygiene after that.
Thank you. Dr. Brady, I'm going to try to go quickly through a few more mask questions that are specific and I don't think we've covered. So quick one, do KN95 masks need to be fit tested?
So if you're planning on using a KN95 as a respirator, recognizing airborne precautions, they say for, say you're working in a facility that can do airborne precautions on a COVID-19 patient, to use a KN95 as a respirator, absolutely. Any respirator, to use it as a respirator, needs to be fit tested. Otherwise, you have no idea whether it's being effective or not. But I'll reiterate that surgical mask and full face shield are an acceptable alternative.
That just answered the next question I was going to ask, so thank you for that. The next question is for Dr. Walsh. It deals with different types of dental treatments. Can hygienists use ultrasonics and polishing June 19th?
Yeah, so the June 19th details are to be finalized, but the plan is to go to non-urgent care then, and certainly those procedures, ultrasonics, would be considered a non-urgent procedure, and however they'd be considered aerosol generating. So depending on the PPE requirements and recommendations for the phase 3 non-urgent care portion of our plan, that would need to be treated, the PPE would have to match up with the procedure.
Maybe I'll direct this one to Dr. Gillis. Dr. Gillis, it's with respect to nitrous oxide sedation. Are there any additional precautions on the use of nitrous oxide sedation, and can it be used to sedate patients in phase 2?
That's a good question. I think that as long as the office plan that has to be developed from the guideline, which is being vetted by Occupational Health and Safety, as long as it takes into account that the nitrous oxide equipment is appropriate, then it would be deemed to be okay to use. But I think this is an area that would have to be, maybe further explored with the board, subsequent to this webinar.
Thank you. The next question I'll direct to Dr. Hayter. Are we being mandated to take temperatures of patients and staff?
It's actually not mandated. It is in our manual put in as a consideration. It is my understanding from the board that it is not a predictable indicator all of the time. And there can be false positives and false negatives. So we do have to consider that. But it is something that our members, if they choose to do it with their patients or with their staff members or themselves, it is something that they can consider.
Thank you. Dr. Albert, I'll direct this one to you. It notes that you must be fit tested for an N95, but fit testing is nowhere to be found in the province. Could you please comment on that? What should a business owner do?
Well, I think I heard some very encouraging comments from Dr. Brady today that says that fit testing may be a thing of the past. If we're not doing airborne precautions, we don't have to have a fit tested N95. You can alternatively use a non-fit tested N95 as a surgical mask. I think, James, you can correct me if I'm wrong there, but even if you didn't get fit tested, it's still an acceptable alternative. So I think the fit testing may become less critical as we move forward and more science is known. The science that has come out of late is very encouraging that this is not the way that the virus is going to spread, and we can diminish our precautions on that front.
Dr. Walsh, did you want to add to that?
Yeah, just a quick addition. So the NSDA document is an excellent resource for fit testing, and there are plenty of places in the province. I inquired about this myself and received a phone call a couple of days ago from a fit testing company saying we can come in now. So it should not be an issue if you consult the document. Lots of good work put in by the NSDA to help make that easier.
Thank you. Dr. Hayter, I'll direct this question to you. Are we allowed to use air conditioning in our offices?
There is nothing in the guidelines nor in my manual that would indicate that we are not allowed to use air conditioning.
Thank you. The next question is on gloves. Dr. Brady, can you review where our gloves should be positioned in regard to lab coats and gowns, i.e. the sleeves are tucked into gloves or sleeves over gowns? Well, actually, Dr. Gregoire, maybe you answer that. I apologize. I thought it was more gloves, but I think it's more to do with gowns.
So yeah, what I was trying to explain is if you have a lab coat that's not cuffed, then if your gloves allow, depending on the type of glove that you use, to tuck the cuff of the lab coat under the glove.
Thank you. The next question is for Dr. Brady. Is polishing considered an aerosol generating procedure?
So at this time, any kind of rotary instrument, be it slow speed or a polisher, is considered aerosol generating, appreciating that there's more work needing to be done on this. And also from a practical perspective, you can imagine a polisher is going to make less of an aerosol than an ultrasonic device or a high-speed handpiece. But at this time, yes, albeit likely small. More research needed to help quantify these things in the clinical setting, but also recognizing that even if you are doing polishing and it's considered a AGP, certainly within the guideline that currently exists, highly doable with a gown and a surgical mask and a full face shield.
Thank you. A few questions on this. Is there a plan in place for June 19th? Will PPE requirements be adjusted or different? Dr. Gregoire?
Again, it's difficult to answer that question because it's going to depend on it'll have to be done in conjunction with the Chief Medical Officer of Health's office, and it'll depend on numbers as well. So again, I'd be speculating at present to try to answer that question.
Next question, I'll ask Dr. Gillis to answer. Any idea when hygiene will be back to work? When can hygiene services resume?
Well, dental hygienists could go back to work on June the 5th if they fit the criteria for the provision of emergency and urgent care. But most of the things that hygienists would be doing for patient care would likely resume on June the 19th with the resumption of non-urgent care.
The next question is for Ms. Crawford. I'll direct to Ms. Crawford. How often should high-touch areas be disinfected?
So there's no set times for disinfecting, just as much as you feel that they need to be disinfected. I think I don't think there's any set times. No.
Thank you. And we've had a few questions on this. I'm going to direct to Dr. Gillis. Has there been any discussion on doing routine testing for COVID for dental professionals? Is a requirement of COVID testing for dental professionals?
No, it is not a requirement for testing of dental professionals at this time.
Sorry, just scrolling through the questions here. There's another one on lab coats, Dr. Gregoire. Some lab coats have zippers versus snaps. Is this all right? Are we expected to have long gown, or are the shorter style ones sufficient?
Again, any zipper, button, snap will work. But again, if you doffed a zipper, then again, you should be very careful when you're doing it, because it's a little more technically challenging than pulling snaps apart. Similar with short versus long. There's no evidence to suggest one's any more protective than the other. But again, you got to use your clinical judgment depending on what you're doing as to what protective garment you use.
I'm going to group two questions so we speed up a bit. They're both to you, Dr. Gregoire. So if a lab coat isn't reusable, do you have to have a different cloth lab coat for every patient? And does office-specific clothing change include the reception and office manager changing upon arrival and leaving the office as well?
So the protective clothing, scrubs or dedicated clothing intended for people involved with direct patient care. So the answer to that would be not necessarily for reception staff. The second question was, yes, certainly after an aerosol generating procedure, the lab coat, if it's reusable, should be discarded again in an appropriate linen bag and a new one donned for the next patient. If you're doing quick checks on patients, then again, you don't. It's not a requirement to wear a protective garment. You should have gloves and a mask on, though.
Thank you. The next question, I'll direct again to you, Dr. Gregoire. Are loops alone acceptable eye protection for an AGP if they have side protection?
As it's written in our guideline, no. So you should use a face shield over your loops. I use a headlight when I operate, so many manufacturers will provide face shields that will accommodate loops, similar to the headlight I use when I operate. So yeah, the way our guidelines are now, loops for an AGP would not be acceptable.
This is for Dr. Brady. Can we wear the same N95 mask all day? What about wearing the same mask 3 days later? At what point are they no longer effective?
So there's significant resources on the CDC website, dental settings, as far as maximizing PPE at this time. At this time, it's certainly acceptable to wear an N95 all day, unless it's visibly contaminated or soiled. It's meant to be changed. There is a reference in there about putting it in a brown paper bag and keeping it for 5 days, recognizing the lifespan, sort of the maximum lifespan of the virus, a brown paper bag on purpose because it helps dehydrate it, and keeping it for reusing it 5 days later. But I would encourage people to go check out that resource for themselves. In my mind, I think the most reasonable, low risk, makes sense way to maximize your PPE would be to use that N95 for as long as you can for that 1 day, and then dispose of it.
Thank you. Dr. Walsh, we've had a few questions that I'll summarize on the 2-week delay. Why did you choose 2 weeks? Will the non-urgent procedures suddenly be safe after 2 weeks? And why are you recommending minimizing use of AGPs during phase 2, but not during phase 3?
Great question. So the ultimately the back to work plan was Dr. Schrang's call, and we have to go by their advice. And it was also discussed. There was always the possibility to go back to work and be able to do everything right away. We feel strongly, consulting with the NSDA, that having a couple of weeks to get used to the new protocols, to settle into the COVID world, the new realities, would be prudent. So this is a bit of a test drive. Again, we're going to have to reevaluate our guidelines and our recommendations, and also have the blessing of the Department of Health when phase 3 does come, hopefully in a couple of weeks. The question about PPE requirements, currently the plan is that they will be the same, and if there is any change in the PPE requirements for phase 3, that will be passed on to registrants in a timely manner.
Thank you. The next question I'll direct to you again, Dr. Walsh. Is a new crown delivery okay when the patient has lost her temp for some time, even if there is for no pain? Is it the same for a fallen off permanent crown? I'm assuming that's obviously for phase 2.
Yeah, so thanks, great question as well. If you look at the urgent dental care section, a lost crown would be considered something that would be allowed to be done currently, and can be replace the temporary, or sometimes it may make more sense to put the final restoration on.
Another question on masks. It may have already been answered, but just to be clear, should our N95 masks state that they are, quote, surgical, unquote, Dr. Brady?
So that's sort of getting at the slide I had with the Venn diagram showing that all N95s are not created equal. So you could very well have, an N95 that's NIOSH approved that would be sort of considered good for preventing fine particle inspiration, but won't necessarily give you any fluid protection. Of course, that is one of the things that we need performing procedures, AGPs, procedures that make droplets and spatter. So that's why I would encourage anybody that has N95s, plans on using them, to make sure that they know what they have and look at the package, understanding that NIOSH approval alone won't give you fluid resistance. So if you have that product and it's not stated that it's a surgical N95 and it's not been tested for fluid resistance, the workaround for that is to put a surgical mask over top of that, because as mentioned, they all have reasonable fluid resistance, or a full face shield.
Thank you. Next question will be for Dr. Walsh. Can you give examples of slow speed use that would not be an aerosol generating procedure? For example, removing of ortho adhesive from an isolated tooth.
I think Dr. Brady handled this earlier. Anytime you use a hand speed, a rotary instrument of any sort technically will generate an AGP. Whether it has water or not, the risk goes up. If there's water, of course, there'll be more aerosols generated, and the faster the RPMs, the more aerosols generated. So in the specific question about removing orthodontic cement, I believe it was, that would certainly be considered an AGP, albeit a lower risk than a high-speed handpiece going full on with water spray. So PPE considerations appropriately for the procedure.
Thank you. Just scrolling through the questions now. Yeah, this is a good question. If it is deemed necessary to refer a patient to a clinic capable of managing them, is there a list of specific offices? Dr. Gillis, can you take that? Sure, I should have given you a heads up in advance.
I think it's important, before doing the referral, that you discuss with that particular office to ensure that they have the precautions that they can take to treat that patient properly. So there won't be any more emergency dental clinics per se, but it's important for that individual to be referred to an appropriate facility.
Dr. Gregoire, this question will be you. We only have time for 2 more questions. I would say there are a number of questions that were submitted. Some of them I think we've already covered, but again, for the ones that we have not, is our intention to post a list of frequently asked questions on the board's website in the coming days, and we'll make every effort to address all of the questions that have been asked in their substance in those frequently asked questions. So Dr. Gregoire, how long of a time do we need to clean between patients, and when can an operatory be used again for the next patient?
So again, I've alluded to this already. So once you're finished care of the patient that you've just treated, the room can be disinfected immediately, and the next patient brought in once the room's been appropriately disinfected.
This next question I'll direct to Dr. Gregoire again. For practitioners who are high risk, like immunocompromised or pregnant, should there be additional precautions that they take? Actually, maybe I'll ask Dr. Hayter to take that question. It's an office protocol question. Apologies for that.
It's actually not listed in risk factors, but if Curtis knows something that I don't know, maybe I can send it to him.
So again, with the appropriate protective equipment and donning and doffing of that, and implementing all the elements of the guideline into your practice, then no, you should be safe to, regardless of, particularly given the circumstance we're in now with very, very low numbers, and using rigorous screening to keep it out of our offices. And as I mentioned, using the guide, implementing all the aspects of the guideline, then it's designed with several layers of safety. So.
Thank you. This will be the last question for today. Are we required to wear shoe coverings and hair coverings, Dr. Gregoire?
Again, it's not mentioned in our guideline, but if that's something an individual practitioner feels they should do, then by all means, they certainly can implement that in their plan. But certainly we don't, it's not a recommendation in our guidelines right now.
Well, with that, we've gone a bit over time and run out of our time. I would like to thank all of today's presenters and participants as well. Dr. Albert, Dr. Thomas, thank you for your remarks, and thank you to all the attendees for participating.